Hello everyone. Today I will explain the advantages of the uniportal technique in disc surgery, comparing it to the unilateral biportal procedure. Regarding the uniportal approach, we need to mention two main subgroups, transforaminal and interlaminar. What I will talk about is the transforaminal technique because both of the interlaminar monoportal technique and the unilateral biportal technique are similar techniques. Both methods are posterior approaches. The dura is viewed from the posterior, so they are like microdiscectomy. What is distinguished here? The transforaminal unilateral endoscopic technique. I have no financial interest or relationships to disclose. This is my hospital in İzmir. Optical systems only for inspection of the intervertebral space after completed open surgery have been used since the early 1980s. In 1983, Hausmann and Forst described a nucleoscope used during open discectomy to ensure that the loose intradiscal fragments were extracted adequately. Then, uniportal access was used for foraminal and extraforaminal disc surgery. The compression of the lateral recess, or at times, removal of a paramedian intracanalicular disc fragment via foraminal access has been reported. However, it will be necessary to wait until 1996 to publish modern monoportal transforaminal lumbar endoscopic discectomy in today's sense. Kâmil published endoscopic images of traversing route in this publication. In addition, the instruments used by Kâmil were passing through the endoscope's working channel. Thus, the two essential conditions of modern monoportal endoscopic surgery were fulfilled, reaching the interepidural space and performing all procedures with the instruments passing through the endoscope's working channel. The first article describing the endoscope and surgical tools working within the spinal canal was published by Ditzford in 1998. Ditzford used a curved endoscope. It was disposable and expensive. The endoscope he used to see the spinal canal was separate, and the endoscope through which he passed the disc remover was separate. This system was not widely accepted. Yeung published the original inside-out technique in 1999. The intradiscal pain generator was removed after placing the cannula in the intradiscal space through Kâmil's triangle. Hoagland introduced the outside-in technique using a transforaminal approach in 2003. This technique made it easier to reach the L5-S1 disc space. Following the success of transforaminal approach in lumbar endoscopic discectomy, the interlaminar approach was first described in 2006 by Ganchoi. This method was advantageous at the L5-S1 level, which was difficult to reach previously. Spinal surgeons used to weaving anatomy from the posterior adopted this technique. Unilateral biportal endoscopy has been developed to overcome the limitations of percutaneous one-portal endoscopic spine surgery. In 1996, the Antoni published the first technical note in which the endoscope and instrument were inserted independently through two portals. When I look at the publications in the literature comparing uniportal transforaminal endoscopic discectomy with unilateral biportal endoscopic discectomy, I found 4 studies. All of these studies were retrospective comparison studies, and they all came from China. This study is from 2022. The cases were operated on between September 2019 and September 2021. There are 28 transforaminal discectomies and 22 unilateral biportal discectomies. The complication rate of two groups showed no significant difference. However, there was a significant difference in the incidence of anemia. 6 are in the UBE group against 0 in the transforaminal group. The following items in the article's discussion section list the advantages of the transforaminal single-channel endoscopy technique. It is a truly minimally invasive technique. There is less intraoperative bleeding. There is no need to place a drainage bag after operation. The probability of postoperative anemia is low. The surgery can be completed under local anesthesia. Another publication. This publication is from 2022. The cases were operated on between January 2018 and January 2021. There are 20 transforaminal discectomies and 20 unilateral biportal discectomies. Uniportal endoscopy was performed using transforaminal technique. This study found a significant difference between operation times, intraoperative bleeding, and postoperative hospitalization times, all in favor of transforaminal endoscopy. When we look at the West scores at the last follow-up, that is the 6 months after surgery, there is no difference between the transforaminal technique and UBE. But at the 1 month follow-up, both leg and low back pain are better in the transforaminal group. It was stated in the publication that transforaminal surgery is better than UBE surgery in almost every outcome. Shorter operation time, shorter postoperative hospital stay, less intraoperative bleeding, use of local anesthesia, faster decrease in back and leg pain, and much faster improvement in quality of life. This publication is also from 2022. The cases were operated on between June 2020 and January 2021. There are 30 transforaminal discectomies and 24 unilateral biportal discectomies. Compared with the transforaminal group, the UBE group was associated with more hemoglobin loss, more hematocrit loss, higher total blood loss, higher intraoperative blood loss, higher hidden blood loss, longer operation time, longer hospital stay, longer incision length, and more total hospitalization costs. In the conclusion section, they wrote that unilateral biportal endoscopic discectomy has many disadvantages compared to transforaminal discectomy. These are increased intraoperative blood loss, hidden blood loss, and total blood loss, longer operation times, and longer hospital stays, ultimately cause more total hospitalization costs. This article is from 2023. The cases were operated on between January 2020 and November 2021. There are 32 transforaminal discectomies and 30 unilateral biportal discectomies. Transforaminal cases were operated on in the lateral decubitus position. Except for times of X-ray, the perioperative outcomes of the patients who underwent transforaminal discectomy were better than those of the patients who underwent UBE. Compared to the UBE group, the transforaminal group had better WES scores for back pain 1 day and 7 days after surgery. There were no differences between the groups at any follow-up time point after the first month. With less bone and muscle damage, transforaminal discectomy under local anesthesia exhibited less intraoperative blood loss, a shorter operation time, and shorter postoperative hospitalization than the UBE group. I found an English publication in the literature comparing transforaminal discectomy, UBE, and microdiscectomy. This publication also came out of China. This article is from 2023. The cases were operated on between January 2020 and May 2021. There are 43 transforaminal discectomies, 42 unilateral biportal discectomies, and 43 microdiscectomies. Foraminoplasty was routinely performed in transforaminal interventions. This table shows the results collectively. In the 5 consecutive rows above, P is less than 0.001. Considering the results, the operation time is longer in UBE than in transforaminal endoscopy and microscopy. In bedtime and length of hospital stays are shorter in transforaminal discectomy than in both UBE and microdiscectomy. Hospital costs for UBE are higher than both transforaminal discectomy and microdiscectomy. 2 publications are comparing UBE with transforaminal monoportal discectomy, interlaminar monoportal discectomy, and microdiscectomy. Both publications came from Korea. This is a prospective and, in my opinion, critical study. There are 20 patients in each group and 80 patients operated on. To evaluate the muscle damage in these surgeries, they examined creatine phosphokinase and C-reactive protein values on the preoperative and also first, third, fifth, and 7th day after the operation. As the creatine phosphokinase ratio, they took the first day postoperative value divided by the pre-op value. The region of the high-intensity lesion in the paraspinal muscle on the postoperative T2 weighted axial image was drawn compared to the preoperative image. The sum of the cross-sectional areas was calculated. This image shows monoportal transforaminal, monoportal interlaminar, and unilateral biportal endoscopic discectomy techniques. When we look at the postoperative creatine phosphokinase values, the lowest value in each period belongs to the monoportal transforaminal group, and the highest value belongs to the microdiscectomy group. The value of the monoportal interlaminar group is higher than that of the transforaminal group, but lower than that of the UBE in every period. These differences are statistically significant on postoperative day 1 and 3. The creatine phosphokinase ratio also presents a similar ranking with statistical significance. When we look at the C-reactive protein values, there is a similar ranking between the groups with statistical significance in each period. When we look at the order of surgical techniques, according to increasing cross-sectional area of high-intensity lesion, a similar order was formed between the groups with statistical significance. When we look at the transforaminal technique, compare it with UBE, we see a huge difference. When we look at the operation times, the operation time in the transforaminal technique is significantly shorter than the other three techniques. The hospital stay is also significantly shorter than the other three techniques. When we look at the postoperative VAS scores, the best results were obtained with transforaminal endoscopic discectomy on the first and third days. There was no statistically significant difference in lower back pain after 3 days. This is creatine phosphokinase values. Top straight line, microdiscectomy. Bottom dot line is transforaminal discectomy. This study showed that the transforaminal discectomy group had significantly lower creatine phosphokinase and C-reactive protein levels. Also, a smaller cross-sectional area of the high-intensity lesion in the paraspinal muscle. The results indicated that full endoscopic procedures caused less muscle injury, postoperative back pain, and duration and hospital stay. This study compared microdiscectomy with endoscopic discectomy types in terms of cost. Between January 2016 and December 2016, a total of 565 patients were operated on for lumbar disc herniation using any of the four methods. The four surgical techniques used are illustrated here: microdiscectomy, transforaminal endoscopic lumbar discectomy, interlaminar endoscopic lumbar discectomy, and unilateral biportal endoscopic discectomy, UBE. When we look at the results, we see that the shortest surgery time and the shortest hospital stay are in transforaminal endoscopic discectomy. When we look at the costs, we see that the transforaminal endoscopic discectomy provides the most economical treatment. The treatment with the lowest total cost is transforaminal endoscopic discectomy. Also, the lowest incremental cost effectiveness ratio measured by cost divided by quality adjusted life years is in the transforaminal endoscopic discectomy. When we look for a meta-analysis comparing the uniportal and biportal techniques, we found one. It was also from China, published in 2022. They applied meta-analysis to data from 7 articles. However, 4 of them were in Chinese, and I couldn't find them. One of them was a study not on disc herniations, but on stenosis. They reviewed 2 articles in English comparing monoportal techniques and UBE in lumbar disc herniation. We have already evaluated both of these articles. The conclusion section of the abstract states that the uniportal endoscopic procedure provides more significant back pain relief in the early postoperative period. Our last publication is a review from Korea and was published in 2023. All 6 articles evaluated were in English. However, 2 of them were on stenosis and the remaining 4 were on disc surgery. In all articles, biportal endoscopic surgeries took longer. When we look at 2 publications in which uniportal surgeries are divided into transforaminal and interlaminar, we see that in both, the shortest surgery is transforaminal. The interlaminar surgery time is close to the biportal surgery time. All these articles conclude that the transforaminal endoscopic technique has significant advantages in disc surgery compared to unilateral biportal approach. The first of these is that the transforaminal procedure is truly minimally invasive. A single endoscopic working portal can provide excellent muscle preservation. In blood profile and MRI findings, Choi revealed that paraspinal muscle injuries from uniportal surgery were fewer than those from biportal surgery. The second advantage resulting from the first advantage is less blood loss. This is valid for intraoperative and hidden blood loss in the postoperative period. As a result, there is no need to place a drainage bag, and the probability of postoperative anemia is low. Operation time is significantly shorter in transforaminal endoscopic surgery, discectomy. People who experience intractable lumbar disc herniation need surgical treatment if non-operative therapy is ineffective. However, it is a known fact that the patients are afraid of general anesthesia with the thought of not waking up again. Because of this fear, patients may refuse spine surgery and their quality of life may decrease. In such cases, transforaminal discectomy using local anesthesia could be a life-saving option. In the transforaminal technique, low back pain decreases more rapidly than UBE. This results in a faster improvement in the patient's quality of life and a shorter postoperative hospital stay. As a result, treatment costs decrease. Why early discharge from the hospital reduces hospital expenses? The patient's early start to work reduces post-discharge expenses. As a result, the lowest total cost is in the transforaminal technique. The transforaminal approach is the most economical treatment in terms of cost divided by quality adjusted life years. However, in my opinion, uniportal transforaminal endoscopic discectomy is entirely different procedure from microdiscectomy, uniportal in translaminar endoscopic discectomy, and UBE. This is because you see the dura and disc from the lateral side. Theoretically, ventral epidural decompression and intradiscal surgery are best performed using a transforaminal approach with minimal neural retraction. Transforaminal endoscopic lumbar discectomy is a representative keyhole surgery that prevents excessive neural retraction. Video of the lateral view of dura and disc space, one of our cases. We see the pulsating dura. It's a sign of the decompression is enough. In contrast, any interlaminar approach inevitably needs considerable neural retraction and may cause some neural problems. Determining which technique is superior in the current technical situation is complex and meaningless. Applying either method for more appropriate cases in actual practice is more important. Uniportal full endoscopic spine surgery enables a keyhole approach and may be effective for ventral and disc surgery. Biportal endoscopic spine surgery can be more effective for most dorsal pathologies. Aspiring endoscopic spine surgeons should learn both uni and biportal endoscopic spine surgery. Soon, most residents and junior surgeons will be able to learn both techniques in university hospitals. Thank you for your attention.
Thank you very much for your amazing presentation. The historical view, anatomical view, and for your research in this field. Me personally, I don't have any questions, only gratitude for you to explain us. And also, I would like to thank you for letting to see your operation.
Thank you.
Dr. Nurullah Kosmene also thanks you for the lecture and says it was a great lecture. And with your permission, can we start by your question?
Yeah.
One of the Korean articles you showed compared hospital stay times. The average length of stay for microdiscectomy patients was stated to be 8.7 days, and for transforaminal patients it was 3.6 days. Isn't that too much bedtime for both groups?
You mean that they must be discharged for the first day? This is the article. This is and high volume hospitals doing the both procedures and microdiscectomy and endoscopic surgeries. These are not my cases, but there is a obvious difference between the cases.
And in your experience in İzmir Atatürk Hospital, how long patients stay?
We have started the uniportal transforaminal endoscopic discectomy actually less than 1 year, and we are very happy with the results. And we also discharged the patients in the same day or at most the next day.
Next day.
After the surgery.
But what about follow-ups? Do they have to present to you later or only?
Follow up these patients. Actually, this is a startup for us, and we performed less than 100 surgeries by now, and we have one recurrence. We have operated on 1 day, actually in recurrence, yes, and we operated on this patient with open surgery, but day by day our technique is improving, and then the patients are happy. We are happy with the results. I think after we complete much more cases, our results will be much better.
Yes. Me personally, as a resident, our chief operator of spinal surgery, performing all cases all by his own, and even the skin suturing part is not the residence part. So we are not fascinated by small operations, which are good for patients, yes.
Yeah,
But
we are proud of this. Actually, we put this education in the residence program, and then every resident will learn and will perform at least 10 transforaminal surgeries, endoscopic disc surgeries before he or she became a neurosurgeon. And
that's fascinating.
yeah, I think it's the first in Turkey, and also I think it's the first in the world.
Yes, not everyone lets to perform it for endoscope. I mean, not everyone is ready enough. Dr. Serpil Ulutaş also thanks you very much for the beautiful presentations and for all your efforts.
Thank you so much.
Dr. Ertan Sevin also wants to thank you for the presentations.
Thank you so much.
And I think Madonna wants to say something. She's raising her hand. We can't hear you, sorry.
Nurullah, can you turn on her microphone?
Yes. Thank you. First of all, I'd like you to take a moment and appreciate all the hard work. Professor Hasan, you did an amazing job with the presentation, and more amazing job with establishing the platform for the neurosurgical community. Every week we have the opportunity to share the knowledge across the nations, across the international residents, students, and neurosurgeons, and I thank you all with from the depth of my heart for this. And you made me fall in love with İzmir. İzmir is my favorite foreign city. Thank you for your hospitality as well. And I was amazed to hear about the endoscopic surgery, like becoming a part of the neurosurgical residency training. And I had the question about it. And in Georgia, no neurosurgeon, no residents are exposed to, obviously. And what do you think? How long this rotation should be? How much is it? Is it enough? Like 10 surgeries you mentioned is part of the training, but like what is the learning curve for the residents and young surgeons who are willing to become spine specialists?
Thank you so much, Madonna. The great question. About the learning curve. I think the learning curve thing is a bit exaggerated. It varies depending on the experience of the learner. If you have done a lot of minimally invasive spinal procedures, such as transforaminal injections, discography, facet medial branch RF ablation, and are used to recognizing the Scottish tuck on oblique radiographs, your transforaminal endoscopy learning curve will be very short. But if you are a spinal surgeon who has only performed a posterior laminectomy on the spinal canal, then you will want to perform only monoportal interlaminar or unilateral biportal interventions, because even the first step of transforaminal endoscopy, which is inserting the spinal needle into the disc, will be very difficult for you. But if you have done other minimally invasive procedures before that, you will be quite comfortable to start the transforaminal endoscopic discectomy.
There is a question
And
from...
Then maybe less than... generally, it is said that you need to perform 60 surgeries in endoscopic surgery, but I think this is valid for the newbies and who hasn't done anything minimally invasive before, and you are familiar with the fluoroscopy, you are familiar with the minimally invasive procedures, I think between 10 and 20 surgeries is enough for you, will be enough for you.
Thank you very much for your answer, Professor Hasan Kâmil Sucu. Actually, there was a question from Dr. Ozan Bozkurt who asked almost the same question. And he specifies, like, for the beginning to learn endoscopic spinal surgery, the first step for you is to learn transforaminal uniportal endoscopic discectomy.
Yeah, I think that the transforaminal endoscopic discectomy must be the first step.
Okay, thank you very much for answering. I see Dr. Mariam I'm sorry, Natsvili.
No worries, it's Natsvili. It's Georgian surname and it is not easy to express. So no worries. I want to thank you, Dr. Hasan, for your interesting lecture, and also thank İzmir Online Neurosurgery for the great experience what I had with Dr. Madonna. Thank you. It was very interesting. And I remember during this course, we had also Dr. Hayati Aygun, who was also invited in our course, and it was really interesting. And I should highlight that he was orthopedic surgeon, as I know, and if I'm not mistaken. And I am interested in, and I have a question from your subjective feeling and subjective experience. What do you think, Dr. Hasan? Such kind of operations should be done by neurosurgeons, by orthopedic surgeons, or the people who is doing such kind of operation should be experienced in both of them, and they should have both of the qualifications. What do you think? Because the spine surgery is another thing. It is not part of in neurosurgery and in orthopedic surgery as well. So what do you think? Where the border we can make, and what will be your advice for example, people who will be interested in to do this endoscopy surgery, and how they can be experienced more in, and which country you advise to experience more? Thanks.
I think Professor Hayati Aygun will be a good mentor, perfect mentor for you, also for me. And actually, I was amazed when I see the first time Professor Hayati Aygun. He was doing lumbar stenosis surgery, and he was very delicate on his movements, and he were like a neurosurgeon almost. I think sometimes later there will not be a spinal surgeon from neurosurgery or spinal surgeon from orthopedic field. There will be only spinal surgeons. It's not too far, I think. Both specialties will join. Actually, personally, I learned a lot from the orthopedic surgeons by now in my practice. It's not important to names orthopedic surgeons or neurosurgeons.
Because what I mean, Dr. Hasan, for example, if people are interested in to do spine surgery,
the connection is bad, I think.
Has as a residency program, why they should study that? Maybe I think that orthopedic surgery has less than 6 years. So if they want in future spine surgery, why they should 10 or 6 years they will do, for example, 4 years kind of surgery.
Sorry, but I couldn't hear all the words.
I think she means the duration of orthopedic surgery residency program is less than neurosurgical. And
Yeah,
is it
1 year difference.
Is it fair enough that they are allowed to do what we can't, as I understood from your question?
What is fair? I didn't understand. Fair to be in orthopedic field for 4 years?
Fair to provide this kind of complex operations?
These are not in the routine residence programs, not in the orthopedic surgery and not in the neurosurgery pediatric programs. People wants to learn endoscopic surgery, spend their time, their money, and they go somewhere to learn it. And these are not routine programs in these specialties. So if you want to learn, you are spending your money, your time. You are going to some place to see someone, and I think it's fair.
That's a good point. Thank you very much for your answer, which also contributes to my questions. Probably indications for this kind of operations, they are specific for a specific surgeon like you must have one kind of symptoms, clinical presentations, which can lead you, or MRIs, size of problems, which can lead you to
The
minimal.
symptoms must be longer than 6 weeks. At least this is the first point, and it is unresponsive for the medical treatment and physical therapy. And I want to say one point. All the indications are related to complications rate. If you do the minimally invasive thing and your complication rates are low according to general population, and your indications can be higher. I mean, if your surgery has lower complication rates than any other surgery types, you can put the indication more frequently because you are doing a really minimally invasive and harmless, relatively harmless surgery. So you can make an indication for surgery in higher rate than before.
Thank you very much for your answer. Bektaş Açıkgöz, hocam, maybe you would like to ask your question yourself? I'm sorry, I didn't notice it before.
Thank you, Professor Sucu. It's a very excellent and informative presentation. I have 2 technical questions. The first one is, do you always see the anterior longitudinal ligament? Is it possible to see the ligament? This is very
Anterior
important for
longitudinal
us.
ligament?
Yes,
No.
not the posterior, no. because we only feel in microdiscectomy, you know very well.
Yeah.
And the second one, what is your opinion in there is a popular disc surgery, daily disc surgery in British hospitals, especially. They have a different healthcare system. As you know, they have practitioners, general practitioners, and the general practitioners take the care of the patient and take the patient to their house daily, and they took afterwards. What is your opinion? Is it possible to make your surgery daily?
Daily. Transforaminal
Yes.
endoscopic discectomy.
Yes, yes.
I think
Because,
it's possible. It's possible. It can be under local anesthesia, but
yeah.
we are afraid of performing under local anesthesia by now. But we are thinking about to make it under local anesthesia. We are now we are performing general anesthesia. So mostly we keep the patients overnight, and then we are discharging the other day.
Yes.
But if we switch to local anesthesia, I think we can discharge the patient at the same day. It's possible. It's quite possible.
But there must be a healthcare system to take the care of the patient at home by general practitioners or by nurses. I think that must be done.
Yeah, you are right.
And may I ask a second technical question? What is the difference between soft disc tissue and hard disc tissue during surgery while taking out the disc fragments? What is the difference? Do you feel any difference?
No, we don't feel any difference. It's not hard.
So you do you use a nucleoscope, such instrument?
No.
Only...
If we encounter a very hard disc tissue, or if we encounter osteophytes, we bought a high-speed drill newly, and we used only 2 times by now, but it can be used with a endoscopic high-speed drill. You can do everything about hard disk, osteophytes, something like that. And there is no difference.
I think I must also remind my young colleagues not to dismiss the far lateral disc herniations. Mostly they are missed. They must look very carefully.
Yeah, not the transforaminal disc herniations, but the extreme lateral disc herniations actually is hard to recognize. You are right.
Thank you very much.
Thank you for your contribution.
Wonderful. Thank you.
Thank you very much for your questions, Professor Bektaş, and for your answer, Professor Hasan Kâmil Sucu. I think it was an amazing start of February, the last month of winter. In Astana is pretty cold. Doctor,
I think Andrew Netlick want to ask or want to talk.
we can't hear you, sorry.
Andrew, we cannot hear you.
Can we unmute him?
The microphone is closed.
I can't unmute him.
Yeah, it's open. Good evening, dear Hasan, dear colleagues.
Good evening.
Thank you for invitation to participate in this session. Sorry, but I missed the part of presentation, but I appreciate your job. I had the chance to visit your clinic. Sorry, but it was not possible because of war issue, but I
We will
know
wait
about
for
your
you
high level
for
of
the next time.
expertise I know about the highest level of expertise in your institution, and I have just one small question about what are the main differences, in your opinion, between uniportal and biportal discectomy? Is it close, or these are the different options that gives different possibilities, results, etc.?
Between the monoportal, I mean transforaminal when I say monoportal, because transforaminal is interlaminar is completely different. Monoportal transforaminal endoscopy or biportal unilateral biportal endoscopy. If you are dealing with the disc pathology,
Unilateral biportal, yeah, I mean
unilateral biportal and transforaminal. When we comparing these procedures,
interlaminar, uniportal, unilateral biportal.
Yeah,
We
I'm not talking about the uniportal interlaminar. I am talking about the uniportal transforaminal, comparing with the unilateral biportal discectomy. And if you are dealing with disc surgery, simple disc surgery, transforaminal endoscopic disc surgery is quite superior than the unilateral biportal endoscopic disc surgery. If you are dealing with disc herniations, if there is no central canal stenosis, but if you are dealing with central canal stenosis, so you must choose unilateral biportal endoscopic disc surgery, or maybe interlaminar uniportal disc surgery.
Understood.
But if you're dealing with anterior pathologies, which is anterior of the dura, which is located anterior of the dura, so the transforaminal endoscopic surgery is representative keyhole surgery and quite different and quite superior than the unilateral biportal surgery. It's completely, if you are dealing with posterior UBE, if you are dealing with anterior, then transforaminal.
Okay, understood. The key is anatomy of lesion.
Yep.
Yeah. Great. Thank you. Thank you very much.
Thank you.
Thank you again for your invitation.
Thank you.
Thank you for invitation. Hope to see you.
We will wait
in the future. Thank you.
To İzmir next time. I hope to see you next time.
Thank you. Thank you very much. Good luck.
Thank you so much. Ayman?
Thank you very much for asking the question, and thank you for answering it. Are there anyone else who would like to ask or say anything? You can raise your hand. I think no one is willing. So it was very informative lecture. Your experience is very educative. Thank you very much again, Professor Hasan Kâmil Sucu.
Thank you, Ayman.
We hope to see you soon, next Monday, we hope.
Yeah. Okay. Nurullah, we can stop the Zoom meeting, I think.
Okay.
Okay, good evening to everyone.
Bye-bye.
Bye-bye, everyone.